Good afternoon, everyone. My name is Dr. Aslam Dasu. I'm from the Progressive Health Forum. We're the associate host of this webinar. I want to give a very warm welcome to everyone from all over the country and from further afield, from a chilly Johannesburg. It's my privilege to chair this webinar that addresses one of the most challenging aspects of healthcare in our country, made more so by the advent of the COVID-19 pandemic. The alignment of health professionals in providing an integrated service to all who need it is a cherished objective of our democracy. And it's been an abiding preoccupation of the many constituencies that make up the healthcare sector in our country. These efforts have so far produced meager fruit. It's perhaps an indictment on all of us who count themselves as health workers that our sector still remains fragmented, unequal, and crisis-ridden. COVID-19 has laid bare all of the iniquities that we know exist in healthcare and has emphasized the deficiencies. Our long-held and hard-fought dream of a public health system that would be the basis of a South African-inspired and built national health service, being a care provider and employer of choice for all South Africans, has receded with the passage of the years of neglect, while a private sector so poorly regulated that it creaks under the weight of its own profligacy and exclusive access, has thrown into sharp relief the brokenness of healthcare in our country. And yet, even as we face the most difficult global health emergency of 100 years, we struggle to elaborate a national response to the pandemic that would see the mobilization of all health resources rising up to the challenge. We cling instead to petrified positions, we hold fast to outdated views, and insist on the tragic binary of public and private care as though they are parallel worlds. Indeed, some of the practices indicate that they are. No inspired leadership on this necessary collaboration has been evident for the last 25 years, during which time we have spouted banalities and shouted accusations at each other, always succumbing to the perceived suspicion of everyone's motives. For 25 years, those who cherished the dream of a health sector motivated by ethics and excellence, and in service to a nation desperately in need of it, have seen their efforts dashed on the expediencies of false ideologies and ulterior intentions. That must stop. Now, the pandemic demands it. Our countrymen and women look to us in hope, but find their anxieties develop a greater purchase. PHF has been alive to this predicament for a long time. This network of healthcare veterans, professionals, health workers, and activists of every category and practice has made it a mission to serve the country best by persuading as many as possible to come together in this, the greatest challenge of our generation. This webinar focuses on the medical profession, but cannot be divorced from the understanding that all health professions and all health workers be equally engaged. This webinar, although presented in two parts, is really about one thing: the overriding necessity of this fateful moment to bring about and center all our training and commitment to the cause of healthcare to which we have dedicated our lives. Now, this applies to every profession, to the pharmacists, to the nurses, to the dentists and the allied health professionals, to community health workers, to health activists and health promoters everywhere. Today's webinar is but one small step in this effort. And while we focus on the medical profession, looking to align all of them to a focus on the needs of our people at this time, it applies equally to all the other health workers. So in the first part of this webinar, we look at why what I have foregrounded in my comments here is important, before moving to part two, where we elaborate a little on the how. So I'm joined on this live feed by very eminent colleagues, whom you can see, some are hiding. Colleagues, leaders, and activists, as well as health industry decision makers, who will outline in their own words what I have tried to say in these opening comments. As the chairman of the event, it's my singular pleasure to open proceedings of what I believe to be a groundbreaking session for ideas and possibilities for how, as we deal with COVID and for the future that generations to come will benefit from. I'm alive to the admonition of George Eliot, who said, "Blessed is the man who, having nothing to say, abstains from giving wordy evidence of the fact." So I'm going to stop speaking now and introduce you to the first session, where we have 4 speakers, all of whom will bring a critical perspective to why what we are doing is important. The first of these is Professor Glenda Gray, who needs little introduction for many of you. She is an A-rated scientist, a research professor in pediatrics at Wits University, and a professor at the Vaccine and Infectious Disease Division of the Fred Hutch Cancer Research Center. She is probably better known as CEO and president of the South African Medical Research Council, the primary host. So to her goes the honor of the first words. Glenda, over to you.
Thank you very much, Aslam. Patrick, can we have the first slides? So I'm just going to outline in 4 slides the MRC's approach to these webinars. We will be hosting a couple of webinars around medical response and in its totality. So this is one of many webinars, and thank you very much for coming. We're presenting today in 100 days of COVID-19 in South Africa, and I'm happy to be collaborating with the PHF, SAMRC, SAMDP, SAPPF, and IPAF. Next slide, please, Patrick. So I thought I would just let you know what our MRC vision and mission is. So we want to build a healthy nation through research, innovation, and transformation. And we want to do this by advancing the nation's health and quality of life and address inequity by conducting and funding relevant and responsive health research, capacity development, innovation, and research translation. And this webinar is part of our research translation priorities. Can I have the next slide, Patrick? So we have seen, as Aslam has mentioned before, a global and local devastation due to the COVID-19 epidemic. We know today around just over 65,000 people are infected, and we will hear some more today as the numbers get updated. And at a global level, we have more than 7.7 million people infected and almost 430,000 deaths. And this has devastated our countries since December in 2019. We have seen this epidemic devastating our health systems at a global level, our economies at a global level, and has taken away the lives of many citizens in many countries. Can I have the next slide? So what we want to say in this webinar is that we need unity, we need equity, and we need fairness. And these should be our values in our response to the COVID epidemic. We always want our approach to be patient-centered. We want to put the patient in the front, ahead of all other interests. We want to see an integrated response. We want to see the public and the private sector to collaborate for the benefit of those who are affected by COVID-19. And we need all resources for this. We need everybody to support this endeavor in an integrated manner. We also see that the only way we can achieve this is to have a healthcare worker approach. We need all healthcare workers, and we need them to work together to support the response. So we need all hands on deck, and we need to make sure that all our healthcare workers are protected in the endeavor to support and manage people who are in hospitals with COVID-19. Thank you very much, Aslam.
Sorry, Glenda, you caught me a little short there. I thought you
Sorry,
may have...
I told you it was going to be 3 minutes.
Thank you very much for that. It gives me great pleasure now to introduce a very important speaker, because if we try and figure out why we're here, then the answer probably lies in the next couple of inputs. Professor Ames Dye will be the next speaker, and she will try and take us through the reasons that the medical profession has been found wanting in responding to this pandemic. I would say that if we have to listen to one input today and go away with just one thing, you should probably focus on this one. Professor Dye is chairman of the National UNESCO Bioethics Committee, vice chair of the UNESCO International Bioethics Committee. She is credited with entrenching bioethics and human rights, an integral aspect of health sciences in South Africa. She has taken a lead in health advocacy and activism locally and internationally, and has published extensively in this area. She's a visiting professor in clinical medicine, School of Clinical Medicine at WITS, and was former director of the Steve Biko Center for Bioethics. Hello, Ames, over to you.
Wow. Thank you, Aslam. Thank you so much for the introduction. Patrick, I'd like you to start my slides, please. Thank you. I want to thank Glenda for getting the MRC involved in a response of this nature, and also for so skillfully articulating the background to the discussions for today. I also, before I start, want to pay tribute to all that have succumbed to the virus, including the many frontline workers and healthcare workers. I also want to laud those that are dedicated Good Samaritans in our country who work against the clock towards the quest for access to social goods for the poorest of our poor. Could I have the next slide, please? Patrick? Okay, so the question, I've been asked to talk about the ethical imperative of the of this integrated response, and in particular, we're looking at the public-private partnership. And the question we ask ourselves is, why an ethical imperative? I think if we look at the background context of us in our country, the answer is very clear. We hugely unequal societies with great disparities between the rich and the poor. Throughout, we have two-tier social systems, not only in healthcare, but in education and other areas. So this just leads to a perpetuation of the binary society that we are. We also must remember that we have systemic injustices that perpetuate throughout everything that we do. And why do I say this? Because social injustices influence the social determinants of health. We know, it's widely known, that the vulnerable become even more vulnerable during a pandemic. And UNESCO, in its statement at the beginning of the pandemic on COVID-19, actually highlighted the importance of taking vulnerability into consideration. We also know that those that haven't been vulnerable have become vulnerable during the pandemic. So vulnerability in itself can begin within the pandemic. And if we look at the public-private partnership, the triple P, as I'm going to refer to it as we go through, I think we could look at this as responding to the principle of solidarity. And we've heard solidarity being bandied around during this epidemic. And the principle of solidarity would denote a unity of action amongst people with a common interest. People with a common interest are, in this context, healthcare workers. And who's their common interest? What's their common interest? The well-being of the patient. Next slide, Patrick. So, why an ethical imperative? As healthcare workers, we all take oaths upon graduation. And there's a moral authority attached to the oaths, and we need to abide by that moral authority. The oaths will set standards for ethical conduct. They define and assist us with working through new ethical issues, and we've seen many ethical issues being highlighted during this pandemic and new ones arising. And we need to work within the principles of our oaths to address these. When we look at the Hippocratic Oath, it's over 2,500 years old, but its principles have survived the test of time. And you just need to look at the modern day versions of the Hippocratic Oath, like the World Medical Association's Declaration of Geneva, the International Council of Nursing, and also the oaths taken by the health science faculties in this country. They all embody the principles of the Hippocratic Oath. Now, I've looked at all these oaths and I've been able to tease out 6 core principles that underpin all these oaths. And these are to devote life to the service of humanity, to practice with conscience and dignity, to ensure the health of the patient as the first consideration, not to allow certain considerations, including political affiliations and financial, to intervene with the duty to the patient, to maintain the utmost respect for human life, and to pursue justice and advocate on behalf of vulnerable and disadvantaged patients. And when we take these oaths, we do not make a distinction between the private and the public sector, or the haves and the have-nots. So the principles in these oaths apply uniformly to all our patients. I want to draw your attention to a position paper that's been published at the end of May by the South African Technology Network in partnership with a number of scientists nationally and organizations as well. And this position paper is on priority setting for interventions in pre- and post-pandemic management. And there is the website there, which I recommend that you all read. Next slide, please, Patrick. Next slide. And in terms of this report, I want to highlight one aspect. No, go back, Patrick. Patrick, go back, please. Okay, in terms of this report, I want to highlight one aspect, and that's what the report had to say about public-private sector health partnerships. And quote, "So far, the government has unevenly brought the private health sector into a partnership to fight COVID-19, with each largely focusing on their own initiatives to battle the virus. In the early days of the COVID-19 pandemic, there were limited explicit resource sharing arrangements between the public and the private health sectors. Yet, the best health delivery strategy should be based on a public-private partnership model of delivery. those in government who argue that only the state should lead the delivery of health public services, and the private sector and civil society should just meekly follow diktats from government, are simply wrong. Similarly, those in the private sector who argue that only the private sector is the perfect vehicle to deliver health services are also wrong. So medical specialists in the public and private sector and medical professional associations must be at the heart of the intellectual, management, and patient response to an epidemic, not bureaucrats. There has to be a sharing of resources based on a partnership between the public and private health sectors. In such a partnership, the state may lead in some aspects and the private sector in other aspects. In the healthcare sector, public and private hospitals must strike a partnership where the private sector proactively avails beds, medicines, and personnel to the public sector. Joint leadership between private hospital groups, medical aid schemes, and public hospitals should be established during an epidemic. So while, and that's close quotes. So while the Saturn report looks at specialists in public and private sectors and makes reference to them, I want to say that these principles would apply equally to all other resources in the healthcare sector, and in particular, the very important family practitioner, who is usually the first port of call for most of our patients in the country. Next slide, please, Patrick. So when we look at scarce resources and the PPP, this is undergirded by the principle of justice. And within the principle of justice, we will find some sub-principles that could assist us. For example, the utilitarian principle, which actually requires that scarce resources are distributed according to the principle of maximum benefit to all. In other words, there should be a fair allocation of beneficial resources. The egalitarian principle, which requires that scarce resources should be distributed strictly to need. And then, of course, there's the libertarian principle, which requires that scarce resources are distributed according to market principles. Now, the problem here is that individual choice is going to be conditioned by the ability and willingness to pay. And there's going to be limited charity care for the destitute. And if we look at the principle of solidarity, especially in the context of the COVID pandemic, I think we can do away with the libertarian principle, which leaves us with utilitarianism and egalitarianism. And what I think is we need a hybrid of the two. Next slide, Patrick. So how are we going to get the hybrid? I think if we apply what we have in Africa, our African indigenous values, our Ubuntu, and we look at our Ubuntu standard, that's going to help us with the hybrid. And what would the Ubuntu standard denote? Living in solidarity, humanness that is grounded in social life, engaging in the life world of the other without taking a stance of superiority. So in this partnership, no one partner can be more superior than the other. Being human and the right way of being human. And more generally, ethical duties to care for one's fellow human beings in a community so that all can be happy. So that there can be compassion, humility, harmony, respect for persons, responsibility, accountability. In other words, if I look at an ethical PPP, this will give life to what we hear in BT saying all the time. I am because we are. We are, therefore I am. Next slide, please. So how about scarce resources, PPP, and the Ubuntu standard? How do we now apply this? I think if we're applying the Ubuntu standard, we have to have a single set of clinical protocols. There is no room for double or triple standards. When we make triage decisions, we need to really think hard about making those decisions on clinical needs. Whatever we do must be non-discriminatory and must take into consideration that social injustice is a huge driver of comorbidities as well. Next slide, please. Just a reminder from our regulator, the Health Professions Council Guideline, Booklet 7 on withholding and withdrawing care. It states in section 1.5 that healthcare practitioners have a duty to give priority to patients based on clinical need while seeking to make best use of resources. We have a duty not to allow views on age, disability, or other irrational grounds to prejudice our treatment choices. And we always must consider benefits, burdens, and risks. Next slide. Patrick? Okay, so what I think we need to work within, and this is what I'm going to recommend for any partnership going forward, is let's work within a framework that is informed by the Ubuntu standard. And what should the principles of that framework look like? We should include solidarity, respect for persons, equity, non-discrimination, transparency, and public engagement. And public engagement is so important. We've started it today, actually. Next slide, please. Patrick. So in conclusion, what I would like to say is that the COVID-19 pandemic has unlocked several crises, and in so doing has taught us many lessons. There is not only an imperative for a triple P, but there is an ethical imperative for an equally ethical public-private partnership. It would be important to integrate Ubuntu standards into it. And we need to look at the triple P as the beginning of a new normal in the healthcare context. It's the beginning of something that we need to carry into the future as we work towards a more just and equitable society, as we work towards delivery of healthcare services for all. And I want to end with a hashtag that all patients' lives matter. And we all need to contribute to patients' lives being of substance and mattering responsibly. We all have responsible contributions to make. Thank you.
Thank you very much, inspired, and I think it sets the tone very well. The next speaker, Cornelia Asante, who will bring a perspective that we often tend to take for granted, and that is the perspective of our patient, the people who come to us with their fears and anxieties, looking for solace. Cornelia is a law graduate and holds an MSc in medical science. She's the Secretary General of the African Organization for Research and Training in Cancer. The acronym's AORTIC, very useful. She's a member of the WHO Civil Society Working Group on Non-Communicable Diseases and is a member of the British Medical Journal Patient Panel. Cornelia, welcome. Over to you.
Thank you very much, Doctor. I'm going to be addressing you from a patient's perspective. When we come to your practices, we come seeking help to get better and hopefully to improve our total well-being. So all patients in normal times seek timely access to quality healthcare. And whether they're poor or rich, patients share this seeking for timely access to quality health care. But now with the COVID pandemic, the stakes are higher. Patients are hoping that somehow medical sciences are going to not only help protect them from contracting the COVID virus, but that if they should contract it, medical science will save them from being one of the stats of the people who have died. But for me, I want to thank you just at this point for including the patient's voice in these deliberations. I am a private health sector patient. I am a human being. I fortunately have been critically severely ill to know that I am not immortal. As a private sector patient, I would like to see more engagement with us as patients on issues of health justice in our country. Traditionally, our healthcare resources have been shared largely in an unequal manner, where people with the means, the financial means, end up having better access to quality healthcare. Professor Dye has gone through the ethical imperatives and why justice ought to be a very strong consideration at this time. From a patient's perspective, I want you to start inviting your patients, especially private health sector patients, into conversations about health justice. For instance, when I was critically ill with heart disease, I was indicated for an organ. But because I had an underlying breast cancer ailment at the time, my private sector doctor sat me down, educated me that heart organs are in short supply in the country and how the allocation works. And since I had lesser chances of deriving maximum benefit from the heart, the donor heart, it would be better for it to be given to somebody else. I was 37. I could have been very selfish and cried that I be saved. And I want to draw this analogy that people who are in good health must understand that when the stakes are high and national resources are limited as they are at the moment in terms of beds and tests and things like that, we need to be less selfish and more mindful of how health resources can be best utilized for those who need them the most at a critical time in their whatever. But in conclusion, I want to pose some pertinent ethical questions about how we communicate with private health sector patients, because I am worried that conversations, national conversations on national health justice are always done in this fear-mongering way, that things are being taken from the well-heeled, the rich, the ones that can afford medical care. There's very little talk about this idea of solidarity that I'm calling for. We need the medical aid sector to reflect on this. Does medical aid cover give people access, unfavorable access to health resources? In other words, does medical aid, or should medical aid guarantee people who are covered by medical aid access to priority healthcare in a pandemic? Secondly, should medical aid allow private sector patients to skip the line for hospital beds and ventilators that are currently in short supply and will become even more as we reach our national surge? Should access to whether people survive this pandemic be based on the size of their wallet? Yes, I know that I am raising possibly legal issues because medical aid is a form of contract. So people who are covered by medical aid ought to have some reasonable expectation that when they do need the resources, those resources will be available. But shouldn't we be starting to probe some kind of limitation of that medical aid entitlement, cover entitlement in a time of a natural health hazard like we are now. You know, my car insurance, I know that it has some limitation clauses, even though I can reasonably expect to be covered. So maybe we start saying medical aid is not normal times, that we can do some limitation of rights in a justifiable way in the interest of the public interest and for the health inclusion for the majority of our South African compatriots. So as a health activist, as a patient myself, and as a high-risk patient, because I live with 3 NCDs, and there are other issues that are coming to the fore about access, where patients with other conditions are currently not able to access their normal treatments. So in our thinking, we need to say more to patients. We shouldn't just be telling patients, wash your hands, social distance. Those are important public health messages, but we should have more nuanced and more challenging and more ethical discussions with, we cannot take medical aid as a right to help us hoard national resources during a pandemic. Thank you very much.
Thank you very much, Cornelia. I think you bring a refreshing voice to very often medically centered debates that crowd those voices out. So thank you very much for that. Our next speaker is Professor Badla, who is the chief intensivist at Dr. George Mukhari Academic Hospital and an academic at Sefako Makgato Health Science University. He's a part-time cardiac anesthesiologist in private practice and is the deputy president of the Cardiac Anesthesia Society of South Africa. We've asked him to speak because clearly COVID has centered many people's minds on what happens at the very serious part of the coalface, the bleeding edge of it. And Nati presumably can give us some insight into that, as well as the necessary requirements that are placed on all medical professionals to collaborate at this time. Nati, over to you.
You can see my screen. Thanks for the kind introduction. And I'd like to thank the organizers as well for having me in this webinar. The views that I'm going to share are essentially, and indeed, my own reflections on the challenges as an intensivist and working in ICU that covers a massive area, population of 1.2 million with one academic institution in the area, and the challenges that we face in this pandemic. What I would be doing during this talk is really to first paint a picture of what these challenges are, and to bring to everybody's attention that indeed there are actually opportunities in us as a country doing better and seeing as few people demising through this pandemic. And this is what I would actually like to do. Indeed, COVID-19 has brought to the fore why unprepared South Africa is for a crisis of this nature and for the pandemic of this nature. Aslam has actually covered a lot of this first slide that I actually have here, although not in detail. And I thank Prof. Ames Dye as well for painting the similar picture. South Africa is indeed a very unequal society. Thus, of the 58 million people that we have in the country and accessing medical care, 78% of them are in the state sector, with about 20% being funded by medical aid. Most of the bed spaces that we have available are actually in the public sector. Although expenditure-wise, the private sector actually takes up about 50% of the pie for covering medical care. The private sector has been developing and building, and the state sector has tried as well to try and match some of these over time, although not very well. The bottom graphic that you can see on this presentation is how much the private sector between 2013 and 2016 has increased its capacity almost by 10% to meet the needs of their members as their covers actually increase as well over time with cheaper medical schemes. But the mere fact that the private sector spends so much on their care compared to the public sector is a worry and a concern, but we should actually use this to our advantage. Pertinent to this epidemic is actually the issue of ICU beds, as it's become more in demand and are in demand during this crisis. There were no available statistics up until the pandemic hit of how many beds were in ICU, and people then rushed in to actually get the correct numbers as to how many ICUs we have available. And at the moment, there's about 7,200 ICUs available in the country to cover everybody, which is obviously considered not enough, considering the expectations of the numbers we're going to get in the surge. The private sector holds about 70% of these ICUs, with the state sector holding just over 30% of the ICUs. And remembering that the private sector only covers about 20% of the population that needs care. When you look at bed occupancy over time, the private sector will have at least half of the ICUs occupied, whereas the state sector has 80% occupancy of its already depleted resources. In the study done by Joan Scribante and Seth Bagwanji, it's an old study. There's only been one subsequent study in 2008, which showed exactly the similar numbers. Of about 244,000 patients that were admitted over this year period, the private sector actually took in 63% of the numbers, with the state sector taking in about 40%. But we do know that the private sector, especially in the high cares and ICU, sometimes patients that wouldn't get ICU in the private sector can actually be accepted there. The second challenge is the issue of personnel. And this is really something unique as well to South Africa because of these discrepancies. The shortages are throughout all sectors of the profession. And one looks at nurses as a start, whereas private has up to about 500 nurses per 100,000 insured people. Some stats actually go up to about 700 per 100,000. The state sector has a meager 144 per 100,000 insured. And that's obviously of concern. Medical practitioners, and if you split these into GPs and specialists, there's seriously glaring disparities as well there, with GPs being fourfold higher in this private sector than the public sector. And specialists especially being even worse, with about an 16-fold increase of specialists located in private sector compared to the public sector. And these are the people generally that would be running facilities like intensive cares and so on, and those will be focused there. The only advantage that probably exists in the public sector at the moment is the presence of trainees, which probably prop up the system to a certain degree. But really, the rest of the specialties, including physiotherapists, occupational therapists, which might be needed during a period of a pandemic, and pharmacists, are really in short supply in the state sector. Radiological imaging services are a third component that I would like to bring to the fore as a big challenge for us. This again is an old study, around 2013, there hasn't been one that's actually looked at a similar picture. This created a whole lot of arguments when the study actually came out between the state and the private sector. Except for general radiography, which is mainly X-rays, the public sector is really in short supply of the personnel and including technologies for investigation. These will be essentially needed during a pandemic of this nature, especially with COVID-19, in the sense that CT scanning for diagnosing especially those with serious disease and assessing recovery or progression of disease during ICU stays will really be necessary. And the discrepancy between public and private is 13-fold with regards to CT scan, and with some provinces not even having a single CT scan as shown on the graphic at the bottom. So this will bring a big challenge for investigation and managing these patients in private, and gathering these services is not going to be easy in a crisis situation. And interestingly, one of the statements made by the publishers of, or the writers of this article at the end was a diagnostic imaging capacity within the South African private sector is indeed superior to that of the UK's. And personally, I think this should not be taken as a criticism of private in South Africa. And we should see this as a strength that's available to us to tap into during situations of crisis. I would like to tackle the testing challenge, which we all know about as well, as an additional challenge for us during this particular crisis. I've made the slides deliberately busy and just highlighted what I would like to drive as a message with the 4 red boxes here. From the NICD COVID-19 side, for state services, only about 17 sites are listed for COVID-19 testing, which is actually then what the public patients are going to be accessing during this pandemic. And the recent one actually from the NICD, Greenpoint Hospital has been removed from this list, and there's only 16 sites that are listed there. When you compare this to private, with about 141 sites from just the 2 major laboratories, we know that there are other smaller laboratories that are coming to the picture, and other players that have been around but are not actually prominent. So this picture of 141 is really a small amount of what's actually available to the private sector. This then explains, essentially, the challenge that we are facing now with testing. And all of us are actually aware of this component and challenge that's been existing for a couple of weeks now. Fortunately, there have been cries from various professions and requests for changing strategy, but private sector really is available as a resource to actually exploit and use, obviously with a meaningful understanding between the 2 centers. The top graph and the second one at the bottom really depict what's happened as we started the epidemic and ramped up during the period of lockdown up to about 4th of May. And the sudden decline when we came out of the first hard lockdown or level 5 lockdown in testing capacity within the country. And the bottom graph illustrates what's happened between all provinces with regards to their testing capacity, with only one province really showing an inflection downward, but all other provinces really showing mean average testing times increasing up to about 2 weeks for some, which most of us will know that actually does not mean the test is of any value to anybody. The Western Cape has responded to this by changing their strategies, and other provinces are starting to do the similar thing to try and make sure the testing becomes meaningful. The graphic on the left in the middle is one that actually shows public practice compared to private practice. And the private practice, private sector really still stands at below 2 days or 1.5 days from the test being done to being available all round. Now this, for me, I see it as capacity and excess fat available for everybody to tap into. And within this hospital that I actually work in, I have seen in private practice, that testing does not even follow some of the regulations that are available in state because they still do white testing. So the real value and capacity that exists in private is even more than we can actually imagine. And the delays we are seeing in state at the moment are not warranted, bearing in mind that there is such excess fat that exists in the private sector. So these people need to actually be brought in, and we find a way of maximizing the capacity for the benefit of all patients in South Africa. What lessons have we learned from the Northern Hemisphere? It's been interesting watching the march of the pandemic through the countries in the Northern Hemisphere, through their winter, and coming to us over the last 3-month period. And there's really some lessons for us to take home, and I would like to just go through some of these as it informs the strategy that we need to take going forward. Obviously, the epidemic originating from Wuhan in China, they're the first one to respond to this, and in expectation of a major surge, the first structure that created a lot of interest and amazed the world was the building of the Fire God Mountain Hospital, or Hoshenshan, which was a 1,000-bed emergency hospital meant to house COVID-19 patients that needed ICU in China. What is proven over time to everybody is that building major hospitals, which is what the government tried to do or consider at the beginning, does not really resolve the problems. After about a week, only about 100 admissions had been accepted to this hospital, the challenge being mainly staffing of the hospital. And this is in a country that has got about 3.1 million doctors in its country, and they face a challenge of this nature. When this didn't work, suddenly Feng Cheng shelter hospitals, which really were meant to take care of sort of mild to moderate disease patients as quarantining facilities, started mushrooming, being built on stadium and exhibition centers. And in the meantime, where doctors were actually present, renovations were done to meet the demand of patients that are actually needing care by either installing negative flow systems and designating zones within the hospital to be able to care for these patients that actually needed help. So eventually the focus in managing these patients, even in China, was back to the hospitals that existed instead of the facilities that were created. The UK and the US noticed the developments in China because their problems started happening a bit later. They were not going to build a big hospital to take care of patients because that hasn't worked in China. The Feng Cheng model was just coming into play. So they got in through doing the similar thing. And through this, the NHS Nightingale and the Jarvis Center in the UK and in New York came to the fore. Unfortunately, these centers as well suffered the similar challenges. Although the staffing was not an issue with the NHS Nightingale, the center was built within 10 days with 4,000 beds planned originally. Under or just below 6 weeks of the center being opened, it only treated about 54 patients in the center. But the rest of the country and the ICUs that existed around the country were managing sort of major patients. So there's never really maximum use of the center, per se. The Jarvis Center in New York, a similar fate faced it. 4 days to be built, 13 days, they had about 2,500 beds. After about a week, they'd only seen about 66 patients. And after 30 days, when they also started winding up and discharging their last patients, the center had only managed about 500 patients throughout all of that time. Yet, in the meantime, the rest of the city hospitals, which were managing COVID patients, had seen 20,000 odd patients over the similar period, and they were busier than these centers. So what have we learned? And I think South Africa hasn't been too slow to learn as well. We've tried to learn, but we're still probably catching up. Ours is indeed an evolving experience. Fortunately, I have been involved in the advising and designing of the ICU care unit that was supposed to be in Nasrec in Joburg to imitate the NHS Nightingale Center for managing COVID-19 patients in South Africa. Thankfully, the province, learning from what's happened in the UK and in the US, has changed tactic and are moving to actually changing what originally was supposed to be a 3,000 bed ICU facility, a project that seemed to probably cost anything from 2 to 3 billion rand. And as we've seen from the other countries, maybe with not the benefit that one would actually devise, because where we're going to get staff to actually manage this facility, including the hospitals around. The Gauteng province, up to about this past Friday, the 11th of June, had seen about 493 hospitalizations. As far as I know, no cases have been admitted to the Nasrec Center or the field hospitals in Gauteng for quarantining by that time. The Western Cape, on the other hand, has also built an 850-bed facility with a target of 2,000, the Hospital of Hope. And as of the 10th of June, from the reports that I could find, only 16 patients had been admitted there. And I'm not sure if these were either real intensive care patients or fall under the same category of sort of moderate disease and quarantining. So what conclusions can one draw and advise on going forward, bearing in mind all these challenges? And indeed, these are big challenges. And what the picture that I've painted is one of major capacity being available in the private sector. The state sector being heavily burdened and unable to cope once our surge really comes to the fore. My understanding is, and we know from the media reports, that the President and the Minister of Health have started engaging state, or rather the private sector, with trying to create some forms of private-public partnerships to meet these particular pandemics. But we also know that, as Aslam said at the beginning, discussions of this nature have been in existence for a long time, faded over the years, and we've lost traction. COVID-19 has come through and has really exposed our nakedness and our unreadiness to tackle this pandemic specifically, but any crisis of this nature which could happen in the future as well. We need to take this opportunity to actually fast track and get involved in setting up these public-private partnerships in a meaningful way. We need to appreciate South Africa's unique situation with the imbalances of care that we actually have. And between provinces and between sectors, we probably need to stop celebrating what I would like to call false victories, pitting one province against the other in terms of what the outcomes are, when we know that the disease does indeed have regionality, and some provinces will fare worse than others will fare, and it will just be the nature of the disease rather than the readiness of one province over the other. Our care, and this is what Prof. Dai has actually covered, needs to be patient-centered, and our goals need to be patient-centered. We need to have formal plans for future crises, including this one. We need to address this pandemic in particular and say, how can we meaningfully access what private practice has to offer to us? We know we need to fairly compensate the private players. It can't be a system of exploiting that side, and vice versa. The private sector should not be in a position to exploit the state with their demands. This needs to be considered a combined national goal that everybody is trying to work towards. So the pandemic needs to be on a national agenda and needs to be tackled as such, as much as the message of the president alluded to this at the beginning of the pandemic. Streamlining of our guidelines is going to be important, and sharing of resources is going to be the most essential aspect of tackling this pandemic. Patients need to be at the center of these plans, private and public patients. We need to keep the South African context always in mind, but maximize on the gains from this protocol. What we do needs to be clinician-driven, and clinicians interacting with each other throughout all the spheres of our medical profession, informing decisions that are going to be made. We need to conserve the scarce resources that exist in the country. And personally, I think even things like testing kits that private sector has in abundance. In a pandemic, these are resources that belong to everybody. So we need to be engaging private and begging for probably a reduction in wide testing, even in the private sector, appreciating that at some point, we might actually be requiring their testing kits to manage our patients in the state practice. Sharing of resources between provinces, between the private and the public and the private sector within provinces is going to be essential. There will be no point in having excess things remaining in one province, which probably never sees COVID-19 by the end of the pandemic, when other places have been running out. So we need to find ways of moving all the scarce resources around the country. We need to mobilize what we have, including personnel and our radiological services, to come to the fore, and this is always going to happen in the private sector. Open sharing of information is essential in this regard, and all of us need to keep level heads and see this as a goal to fight as the whole country. Thank you.
Thank you very much, Nati. That was comprehensive and very useful information for the non-clinicians in the audience. I think you begin to understand the tensions, the difficulties, the demands and challenges at the coalface faced by all our health workers. We've come to the end of that first session, the why for a clinician-driven collaboration. And we move now into the how, because in particular, the private sector clinicians who earn their own incomes, not salaried or anything of the sort, have an understandable concern about the survival of their practices during this time. But what has been an overriding experience for us at PHF in engaging with these parties has been the primary position that they want to step up to the national response. And for us, that was the key that allowed us to start a much wider engagement with several organizations, and they're listed in your invitation. And we are pleased to have brought it to this point where we believe there is some unity of purpose now emerging. What you'll hear from the presentation and the inputs from the various respondents on the digital roundtable, as we've termed it, it will be an unprecedented discussion on what is likely to be the first arrangement that allows for a public and private integration without a dependence on the state to fund it. And this is the critical difference. So this session is going to be coordinated and facilitated by Dr. Ntutuko Bengu, who is an anaesthetist and was in practice in both England, in the NHS, and in South Africa. He spent most of his career, however, in senior executive and consulting roles in the South African private sector. As a panelist of the Health Market Inquiry. Dr. Bengu is a National Planning Commissioner and leads health sector policy advice there. Tutuko, see your videos live. Over to you and to your panel.
Thank you very much, Chair. Good evening, fellow panelists and colleagues who are part of this webinar. Welcome to the part 2 of the webinar, where we move along with the digital roundtable. After more than 25 years of trying to usher in a health system that is responsible to our fellow citizens' needs, we still haven't got it right. We must ask if COVID-19 hasn't compelled us to finally stand up and deliver an integrated healthcare solution. Therefore, colleagues, we are enjoined to not let this particular crisis go to waste. In terms of proceeding along, Professor Alex van der Heever will speak for about 15 minutes to lay the ground for a fruitful discussion. Panel members will respond in turn, taking about 3 to 5 minutes, because we want to leave enough space for Q&A where all our participants today can pose questions. I will then start quickly introduce Alex, even though one can argue he really needs no introduction. Professor van der Heever holds the chair in Social Security Systems Administration and Management Studies at the Wits School of Governance. He has a background in health systems design, management, financing, and economics. Alex has worked on both public and private sector health reform, has worked both public and private sectors, and he's well known for pushing for meaningful health reform. Thank you, Alex. The floor is yours. Thank you.
Thank you, and good afternoon to everybody. Just going to everybody can see that. So what I'm going to be addressing today with this presentation is a proposal that fundamentally deals with the private medical practices and a holistic response to the crisis faced by private healthcare, as well as the need through addressing that crisis to become part of the broader response to the COVID pandemic and the treatment of public sector patients on private sector platforms. I think quite a lot has been indicated already about the problems, the structural problems that we face within the health system that isn't really ready to be able to share platforms effectively and efficiently, despite a considerable amount of time having passed since 1994. And the sharing of these platforms doesn't always depend on one dominating the other. They very often require that there are coherent arrangements that are developed that enable the participation of, for instance, public sector patients on private platforms and vice versa. We haven't developed those. And there is a complex crisis that has impacted on the country as a whole and on the private health system and the public health system. And what I'm really going to do is to sort of run through what has been a number of discussions on resolving certain of these issues so that there can be a coherent response moving forward. So there has been a process through the Progressive Health Forum to kind of engage the industry participants on potential solutions where there seemed for quite a while to be a bit of an impasse in that trying to establish a public sector solution to some of these issues was slow in coming and is facing the risk that in fact we may need to share the public and the private health sector platforms without proper arrangements being put in place. And as the crisis is emerging within the short term, there is a need to really be able to ensure that public sector COVID patients can be seen on private sector platforms without a constraint being created. So not every aspect of that concern will be addressed in this set of proposals, but what I will be looking at is as part of the discussions as to how to make sure that the private sector response from the medical practitioner side, you really have to be central participants in any response, how they are essentially brought into, effectively accommodated in this framework so that they can be part of the solution. So we have engaged, it's been a discussion with technical experts accessible through the Progressive Health Forum, key representatives of medical practices. We've also engaged in discussions with various corporate bankers to look at other de-stressing solutions on the private sector side. So the first issue is to look at what the COVID implications are for the health system. And they are quite complex. There are some substantial collateral effects which haven't really been predicted in advance. In the one key concern is that the public sector finances are significantly compromised due to the lockdown and the closing of businesses that were at a high risk of transmitting the epidemic. Now, this indirect effect nobody has really predicted in advance, is that the impact on society and the economy and on the socioeconomic environment of actually shutting down both the supply side and the demand side of the economy simultaneously has had a dramatic effect on the sustainability of public finances. And that places quite a lot of government responses at risk. It severely constrains what government can do. And one therefore has to look at every measure possible to both unlock the resources for the state as well as the resourcing of society in general, which is generally resourced by keeping the economy functional and going, but that's also a critical part of financing the state. So there's a whole lot of direct and indirect relationships, interrelationships between the interventions for COVID and the implications for public finances. And this impacts directly on the state's ability to finance its response. There's also patient demand for non-COVID healthcare has dropped in both the public and private sectors. So this has a number of different impacts, all very quite complex, including the fact that there is likely to be patients who are going to be severely affected by not seeking health treatment now when they should, and deferring that treatment down the line because they're frightened of coming to healthcare services, frightened of being infected in both the public and the private sectors, facilities and services. So this drop in demand is also not predicted because very few people would have thought intuitively upfront that an epidemic would result in a drop in demand for healthcare. So we have this simultaneous spike in demand for aspects of the healthcare system, and we have a huge drop in demand for healthcare services. So all of that has a complex interaction. The COVID demand for health service, particularly for critical care, that's high care and ICU, is likely to also exceed public sector capacity and may in fact exceed private sector capacity. Now, there has been the initial presentations here, it's been known for quite a while that the bulk of critical care beds actually reside in the private sector. And to a large extent, why the public sector has reduced ICU and high care beds is because they have essentially rationed them out of the system for the last 25 years. So they have been fiscally constrained. They've prioritized district healthcare and HIV and AIDS for a long period of time, which is a legitimate prioritization. But the indirect consequence of that has been that hospital beds have not necessarily expanded at the levels that they should have for our population growth, but it has expanded within the private sector. So our surplus capacity exists in that environment principally. And that is because in that sector is largely demand driven and accommodates the additional provision of beds, whereas the state is quite constrained fiscally and must prioritize heavily. So, but the oversupply in the private sector is an opportunity because you don't need to build any beds if they're already there. You just need to find a way to access them. And it's been a concern, I think, that has been raised, that it's taken a very, very long time for a pathway to be created to access these beds in overriding discussions. But there is a need to solve this particular problem. Then private medical practices and related services are also simultaneously, as a consequence of COVID, in financial distress, arising from the way in which services are financed by medical schemes. They are essentially funded on a fee-for-service basis, so the money is paid to medical schemes, but it is only paid over to medical practices through patient demand. So unlike the way in which the public sector is reimbursed, which is through a budget allocation and salaries, it will continue to be funded, its staff and its professionals will continue to be funded despite any drop in demand for health services, but not so in the private sector. So there is a severe problem at the moment that many medical practices are going to become unviable within the next month or so. And if they drop out of the system, they're not going to be available to anybody. So the pandemic has both direct effects, such as serious illness, and complex indirect effects, which arise from government action and the self-preserving actions of society. So it's to note that a large part of the reduction in demand in the system is not necessarily because of the lockdown, it's because people are scared. And these effects are temporary, but they could result in a long-term structural problem if they are not addressed holistically at present. So the interdependencies involve, on the one hand, reduced public sector finances, which affect the ability of the public sector to contract for private sector COVID-related services, which undermines a unified response. We have increased financial distress of private medical practices, which impacts on their ability to support public sector patients in the absence of adequate compensation. We have a deferment of normal healthcare treatments, which will require a restored healthcare system as the COVID crisis tapers off, creating a medium-term problem that must also be addressed with a functioning and resilient health system. But the expected demand for critical care services and for public and private COVID patients is immediate, urgent, and cannot be postponed, and a response is required that accommodates the crisis in a coherent way. The holistic response to the immediate crisis requires that these three concerns are essentially addressed simultaneously in such a way that the medium-term normalization of the health system also becomes possible. So really that is the sort of the core set of concerns that need to be addressed. If we look at the private sector medical practices, which are crucial to any substantial response going forward, given the extent to which they are available in the private in South Africa, only in the private sector, you have to deal with their financing concerns, which result essentially from a number of contractual rigidities. So essentially, private medical practices private medical practices are presently in a state of distress, largely due to a technical anomaly on how they're funded. So while the budget for medical practices is effectively allocated to medical schemes ex ante in advance, funding is only triggered when a service is actually rendered. So essentially, this is a contractual rigidity which has unforeseen and undesirable consequences within the current exceptional set of circumstances. I would say that having been part of the sort of health market inquiry as well and health policy reform in the private sector for a long period of time, there are other concerns raised with sort of a fee-for-service system which is completely uncontained. So this is only one of the sort of systemic problems that arises, but it is essentially a consequence of this very unusual crisis. Medical schemes also face considerable uncertainty over the period 2020 and 2021. So while they may accrue initial surpluses due to the reduced demand, it's not unreasonable to expect resurgent demand to run down these surpluses in due course. So when the resurgence is combined with private demand for COVID-19 patients, much of which will involve critical care, surpluses may become deficits. So there is a concern that medical schemes have that is entirely legitimate over this period. So the problem in which there's likely to be a instability and a degree of unpredictability around the future is really not confined to the 2020 period. It definitely extends into 2021. So addressing a contractual rigidity really requires little more than the mutually agreed introduction of flexibility. So rigidity, you respond to the degree of flexibility. So if achieved, medical practices would effectively be in a strong position to support public sector efforts to manage the COVID-19 crisis. So essentially no financing is required from the public sector as the funds already reside in private funding pools, which if not spent will essentially accrue as temporary surpluses, which may however translate ultimately into underwriting losses depending on how things pan out. But in essence, it's a relatively simple matter to unblock these resources as they already exist. So if we look at the strategic approach, the first aspect to deal with is to de-stress medical practices, which would allow them, put them in a position to allow for a cross-subsidy to de-stress public health COVID response through a reduced fiscal requirement. Important to note that the public sector is not really in a position to even pay for the full cost of COVID-related services going forward. I've looked quite closely at the per diem that's been developed. There's already a very significant cross-subsidy inherent in that, and there's likely to be an ongoing cross-subsidy if required. So the public-private collaboration, essentially when you see the two together, is to address the current COVID demand for public and private sector critical care beds through the de-stressing, the combined de-stressing of the two systems, which would ultimately preserve a reasonable degree of stability within the system to cope with sustainable public and private sector platforms in the medium term, on the both platforms in the medium term. So if we look at the de-stressing discussions that we've had so far, there's a kind of a basic spectrum of support. We have had discussions with the banks on allowing for interim bridging support through existing distressed business loans, which are available to medical practices. These are consistent with the 200 billion rand state guarantee fund that's been allowed for these loans, which allow for 6 months of running costs to be covered, a 5-year repayment period, available to businesses that were viable and profitable prior to COVID. The next set of supports is really looking at restructuring the scheme contract to smooth benefit payments over 2020 and 2021, and thereby to share the risk of COVID-19 pandemic more effectively across the immediate and wider impact period. So this would ensure stability over 2020 and 2021. So The specific framework that has been discussed and has been sent around as part of a memorandum is a framework which has a number of key elements to it. And I'm going to run through these because they would be the core focus of the discussion. The first issue is proposed that the reimbursement of medical practices be converted from full fee-for-service into a combination of a capitation fee component funded in advance on the basis of a monthly drawdown, referred to as the capitation fee, and an equivalent to 70% of historical experience, and a fee for service for the remaining 30% of historical claims, referred to as the risk fee. So essentially the idea is to move away from complete unrestrained fee for service and combine an advance payment portion which would be available on a drawdown basis, irrespective of the number of claims that have been experienced. But 30% of that fee would be in anticipation of normal claims. So 70% is seen as a measure to core fund the basic overhead costs of practices. The percentage chosen is at a level that seems reasonable to accommodate a wide range of practice types. The value of 30% is regarded as sufficient to accommodate variable costs associated with patient activities, where these activities exceed 70% of historical claims experience. The second feature of the proposal is that overall reimbursement would be capped. This is referred to as a global cap at 100% of the 2019 activity experience, referred to as the base year, and this would be applied by medical practice. And essentially this is multiplied by the relevant price agreements to achieve the total sort of volume of cost. So that is a global cap that would be applied overall. So somebody who essentially submits claims in excess of 100% would not receive any further reimbursement beyond the 100%. The global cap would also be adjusted for declines in beneficiaries covered, and that also deals with the risk that medical schemes face, that they could a drop in medical scheme members during this period. But essentially this would have to be consistent with the with a weighted decline in medical scheme beneficiaries and contributors during this period. So for any within-year reconciliation, this adjustment would be applied to the risk fee portion rather than the cap fee. So the within-year refers to 2020 or 2021. So any reconciliation to 100% cap, 100% global cap, would be applied principally to the risk fee portion. So if there's a decline in beneficiaries, you're not adjusting the 70% initially, but largely the risk fee portion. And that's to just protect the overhead costs of practices as far as possible. So the cap fee would logically be adjusted if the contribution revenue decline exceeds 30% on an annualized basis. So if there's a very, very substantial decline in beneficiaries, then you would only at that point would you have to consider going into the 70%. So the third is that the global cap would apply to the full year. It would not be on a month-by-month basis. In other words, the cap to 100% claims wouldn't be applied monthly, but on an annualized basis. In 2020, the cap can be designed to apply to a period from 1 April to 31st of December, as the first 3 months could be considered normal from a claims perspective. In 2021, the global cap would logically apply to the full 12 months. Fourth aspect is the capitation payment, which is equivalent to 70% of demand in the base year, would be allocated as a fixed fee advance payment in anticipation of the delivery of benefits to medical scheme members. So it is expected that there will be claims against the 70%, even though it's paid in advance. So this is consistent with the definition of a capitation agreement contained in Regulation 15 to the Medical Schemes Act. Just to clarify that, a capitation agreement means an arrangement entered into between a medical scheme and a person, whereby the medical scheme pays to such person a pre-negotiated fixed fee in return for the delivery or arrangement for the delivery of specified benefits to some or all of the members of the medical scheme. So in essence, this is an equivalent payment to this. It's an alternative reimbursement mechanism to conventional fee for service. In sort of conventional textbook terms, it would be referred to as a a fee-for-service cap agreement. So the fifth aspect would be that the risk fee, the residual 30%, would be paid out for all claims in excess of the capitation fee. So medical scheme practices would continue to submit claims as with the normal fee-for-service arrangement. These claims would be offset against the capitation fees paid, with any residual claims paid out until the annual global cap is reached. The sixth feature is that while the arrangement works best with risk benefits, it's also envisaged that medical, dental, and related practices that derive their revenue substantially from medical savings accounts will also be supported through this framework. So where appropriate, the capitation fee will be recouped from a member's medical savings account when a claim is submitted. So in essence, the fee is paid in advance, but the retrospective claim is effectively drawing down from the medical savings account at the point in time at which the claim is submitted. So that provides a framework to allow for the medical savings account portion to be accessed. Seventh, the medical practices must continue to provide services to members despite the capitation fee. So the idea is that people don't go on holiday because they're getting an advance payment of 70%. So it is understood that it would be appropriate for service level agreements to be considered by medical schemes to address this requirement. So eighth, as a measure to protect the public, balance billing agreements and limits should form part of the agreement. So the ninth, the annual price increase into 2021, it's proposed in this and discussed, and it's been discussed with various representatives of medical practitioners, that it should be fixed at the consumer price index, which is a major break from the past in this crisis. And so this is needed to minimize medical scheme, also minimize medical scheme contribution increases in 2021 due to the condition of the economy. So it allows also for the fact that medical schemes minimize their contribution increases as far as possible, given the fact that the benefits have been kept for a major portion of their budget. So while it is a conservative increase, it's proposed as a measure to manage uncertainty for members, funders, and medical practices. And it's expected that this conservative approach also be reflected in medical scheme contribution increases. The 10th, for the framework to work for all, participation should be near universal for all medical practices. So as all medical practices achieve a high degree of financial certainty out of this framework, it's hoped that a near complete participation will occur. It is unlikely that medical schemes will support the framework if there's a significant opt-out of this framework. So it does require that there is a high consensus that, that everybody sees advantage in the predictability and in the certainty that is purchased out of this overall framework. It's obviously no one-size-fits-all framework necessarily deals with the wide variation in experiences within the private health system. But the idea is that it buys a degree of predictability and certainty for everybody that participates, so that the system is sufficiently resilient to take on the requirements going forward. The overall advantages of the agreement is that the de-stressing framework has as its foremost outcome the achievement of certain medical practitioners and medical schemes, such that they can carry more risk directly addressing the COVID-19 pandemic in collaboration with the public sector. So the benefits are, first, medical practitioners guaranteed minimum revenue for 2020 and 2021, with the opportunity to earn at least to levels consistent with 2019 without any need for government assistance. Second, medical schemes are insulated against any deferred demand surge in 2020 and 2021, and any COVID-related demand surge affecting medical scheme beneficiaries in 2020. Third, medical schemes are partially insulated against contribution revenue declines. And fourth, the de-stressed private health system is in a position to support and even cross-subsidize public COVID-19 patients when and where required. And fifth, no exemptions are required in terms of the Medical Schemes Act, as all the arrangements fall within the discretion of the contracting parties. So in conclusion, very quickly, the proposals recognize that substantial unresolved issues remain within the private and public health systems that need to be addressed going forward. All parties to the discussions are well aware of this. The apparent narrow emphasis of these proposals should really be seen as solving a particular set of time-sensitive problems, holistically that make it easier to address the wider concerns in both the short and medium term. So we've got macro fiscal concerns, we keep the economy going, risk mitigation to address a shock to the health system, both the demand and supply, and we have a de-risking of the private health system so that it is positioned to cross-subsidize the public system. So I'll finish there.
Thank you very much, Alex. Colleagues, panel members, we started late. I couldn't cut Alex off because we needed to hear the proposal in full. Quickly, I will move on to Dr. Nkateko Mnisi, who is a family practitioner in Nigel in the East End. He sits on boards of the SAMDP as an executive member and a board member of Afrocentric. Thank you. Over to you, Doc.
Thanks, Dr. Bengu. I am representing
I'm so sorry, Doc, just to let all panelists know that we're down to 3 minutes per person. Thank you.
Okay, thanks, Doc.
And Nat, we also need to see you, so if you can show us your video.
I'm trying to press it. It's not able. Can Patrick help?
I suggest you start in the meantime, hoping it will come.
Okay, good. Thanks. Thank you. Yes,
Those who are speaking, I'm sorry to interrupt. Please put your videos off for now. Sorry, please go ahead.
Thank you. Okay, thanks, Chair. I am Nkateko Mnisi from an organization, South African Medical and Dental Practitioners. We are family practitioners, mainly practicing in previously disadvantaged areas, townships, and the SAMDP doctors were negatively affected by the pandemic in a number of ways. One, there's generally been low numbers of patients being seen. I think this is largely due to the fear of contracting the virus when coming to the practice, but also there's a sizable number of cash patients that we generally see, and some of them have not been earning any money, and as such have not been able to access service from the general practitioners. Doctors are available to assist also in the public sector, and there has been a number of negotiations at the different provincial departments of health, but there are serious constraints, financial constraints for the state, even in entering into those contracts. For instance, in Gauteng, after 2 weeks of negotiations, only 66 posts, sessional posts, were made available for family practitioners. So SAMDP is fully in support of an alternative funding model. The SAMDP doctors would want to be part of the integrated health worker response. I will stop there, Chair. Thank you.
Thank you very much, Doc. We got that. We'll then move on straight to Professor Morgan Chetty, who is chairman of the IPA Foundation, as well as a lifetime member of the International Academy of Quality and Safety. He's also on the board of the Office for Health Standards and Compliance. Thanks, Prof. Over to you.
Morgan, you are muted. Can you put your audio on and
sorry.
you focus your camera a little better? We're only getting half your face. There we go. That's better. Thank you.
I want to say that I've listened and looked at the panelists. I think the panelists are going to be covering the private sector status we are in and how serious we are in terms of being seeing adopt in practice. I think I'll be just repeating myself there. I want to say, for me, I want to raise a few questions. The first is, I think our discussion shouldn't be the private sector sustainability alone. I think we should be looking at the healthcare sustainability in the COVID crisis. So I think the debate cannot just sit with the private sector, it's got to sit across the healthcare sector. I think we have lost some ground because the initial debates were very sectorial, and thank you to PHF, we managed to galvanize people to come together and look at a healthcare issue. What my problem is, and I need answers for, we're not going further because we seem to be stuck in a pure political ideology, in a political debate. We need to shift that discussion from a political debate into a healthcare debate. And if we can do that, we'll be able to co-create a solution. And I think we seem to be losing ground here because there's a discordance between the government policies nationally versus the policies in the provinces. And I think this discordance has also left us far behind in trying to catch up or create solutions. So in the few minutes I have, I want to say that a good example of how the public and private sector could work was enunciated by the World Economic Forum and the United Nations. And this is evidence in Kenya, where with strong leadership of government, the United Nations has built a model to catalyze public-private action based on the SDG platform. It is a very tested instrument for engagement and has brought together a variety of private players in Kenya, and they've created a model that they feel can be replicated in Africa. So the point I'm making here is, is government willing to work with us? Is government declaring the fact that the private sector is essential? And if it's so, what have we done wrong not to get our government to be working very close to the private sector? So I just want to raise that at this point and leave it for discussion. Thank you.
Thank you very much, Prof, for a succinct question. We know the question raised. We press on to give the floor to Dr. Chris Archer, who is the Chief Executive of the South African Private Practitioners Forum and a founder and chair of the Gynecology Management Group, and also was on SASOG Council, which is the South African Society of Obstetricians and Gynecologists from 1994 to 2016. Thanks, Dr. Archer, over to you.
Thanks, Ntuku. I'm appreciative of the fact we don't have very much time. I would just like to say that right from the outset, SAPPF recognized the imperative of finding a national response to what was a national disaster. But unfortunately, we have so far up to this point failed to find a mechanism of being incorporated in an integrated response together with the state. So I think that what has been proposed here is a real opportunity to solve two problems simultaneously: the survival of private practice and the enabling of private practice financially to participate in the COVID crisis and to partner with the Department of Health in treating this epidemic. And secondly, finding a mechanism to take us beyond into the post-COVID era. So what I think I would like to stress is the absolute urgency. We are many weeks into this. We are 100 days into this crisis, and we don't have a coherent response yet. And so what I think we need to do very quickly is take a decision in principle to support these proposals. There's a lot of work that's still to be done beyond that, but if we can make that initial decision now and get cracking, I believe the private sector will see the advantages of what has been enunciated very clearly by Alex. And I hope that everybody will come on board. The big concern is the anti-selection bias that may be introduced by practitioners who feel that they can cope without it. And I think that that is something that we really need to deal with and find out to what extent that might be a problem. So I think I'm going to stop there because I'm appreciative of the shortness of time, and thank you for the invitation to participate in this debate.
Thanks, Dr. Archer. We'll then move on to Dr. Mark Human, who is an orthopedic surgeon in private practice at Netcare Olympdale Hospital. He is also chair of the Gauteng branch of the South African Medical Association and chairs its Human Rights Law and Ethics Committee. Over to you, Dr. Human.
Thank you, Aslam. I'm unable to start my video because it has been disabled by the host. I'm not sure why. I'm struggling with some lighting problems because we're being load shedded where we are. And okay, let me see if excuse for lighting problems, but we're having an elite where I am. On behalf of SAMRC, and obviously SAMRC represents doctors across both public and private sectors. And so we have a huge cross-representation and across both medical officer, general practitioner and specialist sectors. It's been very obvious since February when we first got involved with this, and since in the 100 days since we've had our first patient, that the only way South Africa will get out of this as relatively unscathed as possible is by pairing up the public and private sectors. If you add what we have in both sectors together, we still are hopelessly short of the numbers that many of our European and Northern Hemisphere countries had to deal with their version of the pandemic, and they still struggled. So to think that we can get by using only a section of our healthcare resources is just nonsensical. As Chris Archer just said, we have been trying for over 100 days now to find a mechanism to pair these two sectors together, and it has proven very challenging. I'd have to agree with what Morgan Chetty said earlier. There seems to be a significant disconnect between some of the National Department of Health policies and what is going on individually in the provinces. And we've seen that, and it's for obvious reasons, with the Western Cape leading the way contractually in terms of forming a partnership with the private sector. And obviously that came about rather hurriedly because their state sector was being overrun. That has not quite yet happened in any of the other provinces, but it's probably an overdose of hubris to think that we are immune in any of the other provinces from that happening. So I think I've just got a couple of things to say on behalf of the Medical Association. All of our members across every sector, from general practitioner to specialist and everything in between, is interested in pairing up. We want to be able to make this work. We need a mechanism, and we support this funding because it solves a number of the problems. Not all of them, but it solves a number of them. Thank you very much.
Thank you very much, Dr. Human. We will now move to Dr. Lunginyati, who is a managing executive at MedScheme, which manages the administration and claims risk for more than 3 million lives. Her focus is on managing the clinical risk analytics, advisory, actuarial risk, and public policy. Thanks, Dr. Nyati.
Hi, thank you everybody for having me. I couldn't agree more with the sentiments that have been enunciated about the private sector playing a critical role in the national response to COVID, nor can I overemphasize the importance of collaboration. I do think that it's key. One of the things that I also am enjoying about this conversation is that it's clinician-led. For a long time, many conversations are led from the funder perspective or from a policy perspective, which in themselves are not bad, but they lend themselves to different power dynamics, I guess. And so I think it's great to have a clinician-led conversation that has some funding analysis to it. I think I just want to start by saying from a scheme view perspective, it is true that we've seen a 5% reduction in overall claims year to date, but simultaneously schemes have seen a large amount of investment losses on their side. What that means is that there's going to be a need for schemes to consider how they're going to make sure that they keep contributions low while adjusting for the investment losses that they have incurred. Simultaneously, we're expecting some membership losses, both from direct paying members as well as some corporates who are going to lose some of their membership. And as everyone has said now, we also are expecting an increase in claims recovering. So that's just the context from a medical scheme perspective, since we've given context from other perspectives. And so what I think this conversation is going to be an interesting juggle of balls for all of us to be able to make it work together. We are also seeing that it's unlikely that claims will be less than 70% of what schemes were expecting. So while the rationale of the 70% of claims being paid upfront makes sense, I do think it's going to need to be balanced with the fact that what happens if we have already seen 70% of claims being paid out for some provider types, and certainly for some individual provider practices. We love ARMs. We've been advocating for alternative reimbursement models of different kinds. And so it's great that this is one such alternative reimbursement model that we can unpack and get it to work. The majority of our concerns really revolve around the detail of it. And so I think that while the idea behind being able to use an alternative reimbursement model to make sure that private sector healthcare professionals remain solvent, while that's something we do support, we do think that there's some things we're going to have to think really carefully about to make this work, from administrative elements to costing elements to legal, all of which I think have been thought about to some extent or another at this stage. I think the last point that I really want to make is how we think about this. Do we think about this at a global level? So do we think about the spend of healthcare of GPs in totality? Do we think about it per practice type? Do we think about it per practice, the 70% number? Because as Chris Archer mentioned in one of the comments on the chat, one of the things that's important to note is that there are some providers who actually have really low utilization. And for those providers, what you don't want is the scheme to pay you 70% of your expenditure upfront, but then you end up not using all of it because, let's say, the population in that area end up falling off the membership base altogether. So there will be swings and roundabouts. But be that as it may, for us, it's important for us to go through what the problems are we're trying to solve, and then look at how we solve each problem individually using any mechanism that we have. But there's certainly support on our side to work with the clinicians to find solutions and to look at alternative reimbursement models to be able to solve those problems. I'll stop there.
Thank you, Dr. Nyati. I actually skipped Dr. Richard Taft, so we'll go back to him in that order. Dr. Taft is an executive director of the Radiological Society of South Africa. Thank you.
Thank you very much. Radiology has been motivating for this or a similar concept since the beginning of the lockdown. Our view was that the private sector required support through an ARM to ensure the continuation of private medicine in the long term and for the provision of assistance to the state during the COVID pandemic. We have in the private sector been prepared to assist with state patients since the beginning of the lockdown, both by imaging patients in private practices and the use of telemedicine. We, as the Professional Association for Radiology, first wrote to the Department of Health at the end of March, suggesting both approaches and requesting discussions. We are still awaiting a reply. With the immediate reduction of patient numbers, even in the week before the lockdown, radiology practices were not even covering 50% of their fixed expenses. A major component of our fixed costs are staff costs. Each radiologist has on average 5 to 6 radiographers working for him or her, and an additional 3 or 4 support staff. So a large radiology practice will directly support 250 people, excluding the radiologist, and indirectly 1,000. Volumes were reduced because of patients' stay away and due to the cancellation of screening examinations and deferment of examinations where possible. Our priority has been throughout to remain fully staffed, both to provide financial support to staff, but also to allow staff to work in shifts to reduce exposure and keep them safe. Now, the beauty of this proposal is that by supporting the private sector, it allows support of the state sector for minimal or no additional cost. The schemes do not support the state, but empowers the profession to do so. The model works in its basic form for all health professionals, and with cooperation and innovation, it can be made to work for the various clinical specialities and our general practitioner colleagues. However, it's taken a long time to get here, and the longer we wait, the less chance of getting sufficient providers to sign up to prevent anti-selection. Buy-in cannot be coercive, and it will depend on the attractiveness of the offering judged against the perceived risk of not joining an ARM. This is a basic ARM and only deals with risk. Value will have to be included in future iterations, with payments transferred from those who provide value, transferred to those who provide value from those who do not. We look forward to developing different ways of funding private healthcare for the benefit of the whole population, both insured and uninsured. We're very excited with this project. And then finally, purely from the record, in the paper referenced by Professor Mutladla, that paper contained a typographical error which reversed the CT and MRI numbers in South Africa. When that was corrected, the imaging modalities in the private radiology sector were seen to be in the mid-range for OECD countries. We're still doing very well, and we're available to help. Thank you.
Thank you very much, Dr. Taft. The last panelist is Professor Romaine Harris, who is a health policy actuary at Discovery Health. She is also an adjunct professor in the School of Statistics and Actuarial Science at Wits. She's past president of the Actuarial Society. She's been in healthcare financing for more than 26 years, and at Discovery, her role includes providing input into the health reform process, constructive input. Prof, over to you. Thank you.
Thanks, Dr. Bengu, and good afternoon, everyone. Thank you so much for the invitation to Discovery Health to be part of this very important conversation. We strongly support the ethical imperative of a unified response to this crisis and to health reform generally. Although as a country our resources are limited, there is an opportunity to use them effectively, and with the unity of purpose that the speakers before me have mentioned. We are still facing huge uncertainty around the trajectory of this pandemic, and our modelling efforts still have very wide confidence intervals. As both Dr. Gray and Prof. Dye have stated, we are all in this together, and we need to respond with agility and compassion and in a responsible way given this uncertainty. For medical scheme trustees, the primary concern has to be ensuring that members have access to care, that their claims are paid, and that the medical scheme risk pools remain sustainable. But from the outset, we at Discovery Health have also been very aware of the impact on health professionals in terms of reduced patient volumes associated with the lockdown and other appropriate precautions to flatten the curve and manage the surge. We recognize the risk of the sustainability of the health system as a whole associated with this volatility. So since late March, we have been doing extensive work on mechanisms to provide relief to health professionals, while also balancing the need to address the other pressures on medical schemes. These pressures on the schemes include the impact of the additional COVID claims, the affordability pressures that members are facing due to job and salary cuts, and the impact on assets. our estimates of the additional direct costs of COVID claims, which includes both testing and treatment, are between 7 and 31 billion over the next 18 months. As Prof. van den Heever has said, there's lots of uncertainty around how this experience is going to pan out. But we would also agree with Prof. Madlala that the way in which we use testing, for example, is a key area when it comes to managing scarce resources. And these need to be accessible to all South Africans equitably. So there's lots of balances that we need to strike. Back in March, we introduced the WHO benefits to address the need for additional medical cover, and also applied for exemptions from the Medical Schemes Act to address the pressures that members were facing. This included support for SMEs and individual members to make sure that they could retain their cover during these difficult economic times. Our exemption applications also included measures to support the health professionals, and these latter applications were not successful. Circular 33 that was published a few weeks ago makes it clear that the regulator considers that scheme reserves are for the sole benefit of members, and it's clear that we need to work within the constraints of this regulatory framework, which Prof. van den Heever has mentioned. So we agree that there's a great opportunity here to make use of alternative reimbursement mechanisms as a way to promote sustainability for the healthcare providers, while also addressing the needs and benefits of members. The latter balance is really, really key. The trustees are responsible for members' funds held in trust, and so the use of these funds to leverage and to smooth out volatile experience has to be done in a way that addresses and protects member interests. Things like balanced billing and quality of care and more efficient modes of delivery are key to ensuring that there's an appropriate approach to structuring alternative reimbursement models. This crisis has demonstrated that there are risks for providers with the fee-for-service framework, in addition to the risks that medical schemes have been grappling with for some time in terms of escalating utilization, driving up the costs of cover. So I think this is a great initiative, and I'd like to stress that there's a really important need for solidarity here. There's very clearly as an industry approach, we need to address this challenge, both from the funders and from the health professionals. And we really welcome the role that the PHF has taken in leading this. We need to ensure that there's widespread participation and limit the opportunity for arbitrage by opting in or opting out. And I think some of the questions on the chat are indicating an understanding of this risk. I can't stress enough that the feasibility of this proposed framework really does depend on this solidarity. Finally, there's some details to work out, including how this works for disciplines funded from savings and the regulatory constraints. This is a particular concern since the disciplines that are funded primarily from savings include practices that may be less well-resourced and more vulnerable. And so it's really important that this approach is inclusive across the board in terms of disciplines and practices. So thanks again for the opportunity, and we're looking forward to the further discussions.
Sorry, Ntutuko, can I just come in here for a moment? Thank you very much for that, Roseanne. Just to say that given the time constraints, we're going to run the session for a little longer, because I think there's a lot of interest in what people have said, and especially from the last speaker who actually captured everything quite well. So we'll run to about 6:15. Let me hand back to you, Ntutuko.
Thank you very much, Chair. Before I do that, I just want to say that we'll first give panelists opportunity to ask questions of each other before we open very briefly, and responses should be restricted to no more than 90 minutes. What's important, just to summarize, is that quite clearly all our panelists have shown or have expressed support for the proposal presented by Professor van den Heever. Dr. Mnisi clearly defined the problems that are faced by practitioners on the ground, and Professor Chetty also did the same and highlighted, or rather asked a question why government has really not engaged. Dr. Archer as well is asking us that we don't just look at COVID solutions, but what we are proposing must be good for the post-COVID era. But wants a decision to be made now. he raised an important point of anti-selection bias about doctors who will feel they will cope without intervention. How do we balance that with the issue that has been raised, that this will work provided most players are for it? Dr. Human also stressed an important point that it's all supported by he represents, which is SAMRC, but the issue, of course, again, is impairing in how we do it. Dr. Nyati gave us an interesting angle, really looking at what they are seeing from a scheme perspective. 5% reduction in claims, but increasing investment losses. How do they balance that? Again, support, but the question is in the detail. And Dr. Taft went further in saying that they have already been proposing a solution along similar lines, but have not had any response from government. And also that they have been using telemedicine and other technology to try and assist also the public sector. He made a good point that at best, this is a basic ARM. In the long term, we'll have to incorporate the value component to this. And then finally, Prof. Harris also expressed strong support at Discovery and stressed the need for balance, and made also a very strong point that we do need solidarity, solidarity being an operative word here, and also welcomes the role that PHF has taken in this regard, in leading this effort. So quick then, colleagues, questions that you would like to raise among each other. It's now 18:03, so if you can just give 2 to 3 minutes, really, if you have something new to add. The virtual floor is open. Dr. Mnisi?
No, I'm good, Chair, no question.
Ms. Asante, I see you are on as well. Your video is on. Does it mean you want to speak? Okay. Lungi?
Sure. One of the things that I was thinking is that this conversation is a funding mechanism. So the intention is to use funding to stimulate the ability for cross-sectoral delivery, as it were. And one of the things that I think we're going to have to think about is, let us assume that we get this funding right at whatever percentages we agree on. We need to intentionally make sure that there's a framework that enables a private sector provider to actually provide services for public sector patients, so that it's not that after all of this, all we have done is that we've enabled private sector providers to remain solvent, which is important in and of itself, even if there wasn't a need to cross-subsidize services for the public sector. But if part of the intention is to also enable the private sector providers to provide services to public sector patients, that we must build that bridge at the same time as building the funding bridge, is the only comment I wanted to make. And I just wondered whether that conversation is happening maybe via PHF as well. I'm not sure.
Thank you very much, Dr. Nyati. Dr. Archer, you had your hand up.
Yes, thank you. I just wanted to put a question to Professor Harris. Razan, I agree with you absolutely that it's very largely a question of solidarity. And I just wonder whether you would be able to define what do you mean by solidarity? What percentage of take-up would an organization like Discovery Health be comfortable with? I think it's quite important to know what we're aiming for fairly soon, because that would set the sort of the yardstick, as it were.
Please proceed, Prof.
Thanks, Chris. I think there's quite a few details that we're going to have to work out seen some comments in the chat around things like consumables and dispensing and so forth. And the key thing to recognize is that this proposal works at practice level. And so the experience of different practices is likely to be very different, and that's why we need high levels of participation. It's difficult at this stage to pin on whether that's going to be, 80%, 90%, 70%, but certainly it's going to have to be in that order of magnitude in order for this to work. And we certainly recognize that shifting from fee-for-service to alternative reimbursement mechanisms is not something that is straightforward. Certainly, the contracts that we have set up have taken a long time to develop, as both parties need to understand the implications. In this case, we need to fast-track that development, and that's why I think it's important that this is at an industry level as an initiative, so that fast-tracking and that degree of trust that is built up or is critical to making those contracts work is something that we can engage on at an industry level. This is not a competitive issue.
Thank you very much. I think at this point I will ask the chair to take over again because I haven't been monitoring the chat as well. But maybe Dr. Tasu to take over right till the end. Thank you.
Thank you very much for that. I found your digital roundtable very stimulating, and my compliments to all the panelists. You're very disciplined in the timekeeping, which of course as the chairman worries me a lot. But also, let me just give you some final comments. The Progressive Health Forum is really delighted at the clear convergence that has been signaled by this initiative and by all of your inputs. We understood at the outset the necessity for making sure that there was a mechanism that would enable the private sector to act in concert with their public counterparts. Because right now we're entering the mitigation phase of this pandemic. There's likely to be a lot of hurt waiting for the population. And really, in terms of our oath, and as Ames Dye and others have said, we really don't have a choice in this. This has been our calling from the time we started our training. So we remain available as PHF, as a platform, and as interlocutors for all of these organizations in this work that will be ongoing among yourselves and the funding industry. But we will now concentrate our focus on the clinician-led collaboration to deal with the mitigation phase of the pandemic, because really that's the only game in town left once you guys have settled these matters. So I want to thank the MRC for their hosting of this webinar, especially Patrick Charles and Alfred Tutloa, who helped us set things up. I want to thank all the participants whose questions that were listed in the chat group have been very insightful and have all been recorded. And I assure you will be answered by the panelists and the speakers. The answers will be included in the official recording, which will be emailed to all of you. And to the panelists themselves, a very big thank you for lending your expertise and support to this initiative. So in this moment where we are probably still consumed by the potential doom, I was moved by something I heard from Ireland, where one of their leading living poets, Derek Mann, wrote in this time of the pandemic, a poem that I think resonates very strongly with me, and I'm sure will with you as well. And it's entitled, "Everything is Going to Be All Right," by Derek Mann. How should I not be glad to contemplate the clouds clearing beyond the dormer windows and the high tide reflected on the ceiling? There will be dying, but there is no need to go into that. The sun rises in spite of everything, and the far cities are beautiful and bright. And I hear in a rise of sunlight, watching the day break and the clouds fly by. Everything is going to be all right. And with those hopeful words, I want to thank you all for being on this webinar with us. Good night, and thank you.